Dear colleagues, today we present the case of a patient who came to our attention at 16 weeks following the finding in a non-invasive prenatal test of a deletion on the short arm of chromosome 18, for which she subsequently underwent a confirmatory invasive investigation. The deletion of the short arm of chromosome 18 is also widely known as 18p monosomy or de Grucci syndrome type 1, also known as. In most cases, this genetic condition has varying degrees of severity, presenting with different clinical features, which commonly manifest as intellectual disability of varying degrees, ranging from mild to moderate, short stature, distinctive facial malformations such as a noticeably round face, palpebral fissure abnormalities, jaw anomalies, and ear alterations, and an immunological deficiency such as type A immunoglobulin deficiency. However, in approximately 10 to 15% of cases, this particular condition is characterized by a much more severe and profound form, which is precisely the case of a subject that we will now show you in the accompanying images, where there are indeed serious facial and brain malformations that clearly fall within the spectrum of holoprosencephaly. And in this case, the condition is incompatible with life. In the less severe form, this particular condition has an incidence rate of approximately 1 in 50,000 live births, which is quite rare. In 2/3 of cases, the deletion of chromosome 18 is a de novo deletion, whereas in the remaining cases, this particular situation may be attributable to a new translocation with the subsequent loss of a significant portion of the short arm of chromosome 18, potentially caused by the misaggregation of a parental translocation or an inversion of chromosome 18 pod. And therefore, in these particular cases, given the significant possibility of transmission in a future pregnancy, it is absolutely necessary to also carefully analyze the parent's karyotype in order to accurately assess the potential risk of recurrence in any subsequent pregnancies. In this case, we see that the fetus is affected by holoprosencephaly, a brain malformation caused by a failure and incomplete separation of the cerebral hemispheres. This is a case of the allobar form, in which there is a severe lack of separation of the hemispheres, with the presence of a monoventricular cavity due to abnormal development of the lateral ventricles and the third ventricle, which merge into a single cavity. In this case, there may also be associated abnormalities of the facial structure. Here we have hypotelorism, but sometimes cyclopia can also occur. A proboscis, or even an ophthalmia or microphthalmia. In this case, however, both lenses are present, and we can see that at the level of the posterior cranial fossa, the posterior cranial fossa appears normal, with a regular shape and size of the cerebellum, a normal cisterna magna, and a normal nuchal fold. We can also clearly observe that in the allobar form, there is a complete fusion of the thalami. In these detailed images, we can distinctly see that both ocular lenses are indeed present. So we can rule out the more severe forms characterized by facial anomalies, which, as we mentioned, are marked by nostalmia and microphthalmia. We can see, as we continue to look at these images, the fusion of the thalami along the midline, and there is clearly no distinct interhemispheric fissure present. Instead, there is this single unified ventricle with a complete and extensive fusion of the frontal horns, and this is indeed the most severe and extreme form of holoprosencephaly. Naturally, in these particular cases, the prognosis is very poor because this significant type of brain malformation is truly and utterly incompatible with life. Continuing to scroll further through the images, we clearly show you the presence of the single ventricle of the heart and also the presence of the fusion of the thalami along the midline. A characteristic sign using color Doppler is what in English is called snake under the skull, meaning a snake slithering under the skull because the interhemispheric fissure is shallow, and due to the fusion of the frontal lobes, the branches of the anterior cerebral artery are displaced superficially along the anterior portion of the brain, resulting in this typical appearance on Doppler. At the facial level, we also notice a significant abnormality of the upper lip, specifically a pronounced median cleft of the lip. Usually, the severity of the cerebral malformation often correlates directly with the severity of the associated facial dysmorphisms, which is an important clinical observation. So, at the facial level in this case, in addition to hypotelorism, which we have already seen in the previous images, there is a median cleft of the lip of about 3 millimeters, as we can see from these images. Furthermore, we also see that the nasal bone appears hypoplastic. The rest of the fetal anatomy appeared normal. Here in these images, we see a normal four-chamber view, a normal primum and secundum septum. The drainage of the pulmonary veins into the left atrium is normal, as is the left section or the aorta, the right section, and the three-vessel trachea view. So the cardiac anatomy appears absolutely normal, and the right subclavian artery is normal as well. Furthermore, in monosomy 18p, as we previously mentioned at the very beginning of our discussion, there can be a significant association with growth retardation or noticeably short stature, which in this particular case we unfortunately did not find. In fact, the fetal biometry is entirely normal for the current gestational age, so here we can clearly see that the abdomen is quite normal for this particular stage of development, and furthermore, there is absolutely no evidence of short stature, as we can readily observe that the femur length is also completely normal. Additionally, the fetus did not exhibit any signs of hypokinesia or joint stiffness. This was observed in all four limbs, so here we clearly see the lower limbs, which appear perfectly straight and entirely normal, and we can readily observe the normal fluid movement of these lower limbs. Likewise, in the upper limbs, we consistently see normal movement and also a widely open hand, which is a very positive sign that there is absolutely no significant hypokinesia, which can be quite characteristic in these particular circumstances. This observation does not fundamentally change the overall prognosis of the fetus, which, as we have already clearly stated, is unfortunately incompatible with life. Then, when we carefully assess the amniotic fluid, we observe that by meticulously examining all four quadrants, the overall amount of amniotic fluid is found to be at the absolute lower limit. Furthermore, the amniotic fluid appears particulate, as we can clearly see, and for this reason, we naturally went on to study the renal anatomy, which appears normal. This indicates that the reduction in amniotic fluid is not due to a renal pathology. Additionally, the bladder also appeared normal, with a normal umbilical cord containing two arteries. Therefore, an underlying renal problem as the primary cause of the reduced amniotic fluid can be effectively ruled out. In conclusion, the clinical picture described and shown in the images is a clinical scenario incompatible with life. It is necessary to specify this crucial information in the report because even just the finding of the microdeletion in the fetal DNA and with the significant ultrasound findings, the patient can access voluntary termination of pregnancy. Alternatively, if there had not been clear and evident anomalies observed on the ultrasound examination, the significant finding of a deletion of the short arm of chromosome 18 on the NIPT results should instead definitively guide us toward performing a more invasive and confirmatory amniocentesis procedure. This is primarily because in some specific cases, there may be placental mosaicisms that can significantly alter the NIPT result, leading to potential inaccuracies. Furthermore, it is necessary to carry out a comprehensive genetic consultation to thoroughly rule out the potential risk of recurrence within the family. In particular, it should be carefully remembered that the risk of recurrence of this specific deletion is generally quite low for de novo deletions and translocations, but is significantly increased if a parental rearrangement is indeed present. Therefore, both members of the couple should always undergo thorough genetic testing to definitively rule out any possible parental rearrangements. Thank you all for your attention.